with the phase 3 study on the use of P53 inhibitor. Do you have any explanation for, let's say, lack of difference between the two arms? Because phase 2 studies were so encouraging.
Yeah, no, thank you for the question, Dr. Cazzola. And actually, I think, even somewhat more impressive, looking at the combined data and some of the long-term results, particularly in patients going to transplant, that will ultimately present at this meeting. I think there's a couple of issues. One, this was an open label study, and there may very well have been some imbalances. So, patients that were randomized to the azacitidine arm, could have come off study beforehand, and that may have created some biases, sickness of patient, severity, complex cytogenetics, mutation status. All of that is being analyzed and will eventually be presented. I think another issue, and we're now learning this across multiple failed phase 3 studies, and I'm actually very interested, looking forward to Dr. Sekaris, presenting the Panther study data. With combination trials going to large centers, sometimes, dose adjustments, may potentially be inappropriate. So I think a lot of HMA venetoclax may have guided some of this, where many patients need whole dose interruptions, dose adjustments. If you look at the phase 2 data across both of our US and GFM trial, there was only one patient period that was dose reduced on azacitidine. Again, potential interruptions and may be needed, but our thought is that the synergy really is with the two agents, and if aza may have been inappropriately reduced more than expected, that may have also dropped our some of the synergy that was seen. I think looking at patients with and without dose adjustments will be an important look into the future data as well.
Okay, one question is, how do you manage these patients outside the clinical trial? I mean, TP53
Yeah, no, it's obviously a challenge, and I hope that the presentation somewhat emphasized, of course, the urgent need to get these patients on study. For patients that are, fit and otherwise transplant eligible, of course, there's a lot of data, and some even academic centers have gone away from allogeneic stem cell transplant. Our goal is to reduce VAF as much as possible. With MDS, I actually still just go forward with single agent HMA. I don't think the data are clear that venetoclax necessarily improves outcomes in that setting. We typically do single agent HMA. If we can get a good response, particularly cytogenetic clearance and/or VAF clearance, we do try to bridge them to transplant. And really, all these patients, I do post-allo maintenance. Those trials have overall been negative, but subsets in P53 have been inadequate. So kind of this sort of, again, total therapy concept. For patients that don't get cytogenetic clearance or have persistent P53, another group that potentially, if you have novel cellular immunotherapy trials or others, may be something to try to deepen the remission before bridging to transplant. In the elderly group, still, with single agent HMA, we'll sometimes add venetoclax based on a lack of response after a couple of cycles. And you can get blast clearance, but whether or not long-term outcomes are improved, I think, is an open question.
Okay, thank you very much, David.